So I'm going to talk about ADHD throughout the lifespan, and like Tanya, I'm more than happy to be interrupted or have people ask questions when they're pertinent. But we're going to, and I'm also very aware that most of you are from general practice environments, and so I'm very, very interested in making this as practical and as applicable as possible. And I'm also interested in making it fun as well, and hopefully I'll be able to do that. So please, like I said, feel free to pop your hand up and ask any questions as the time goes on. I'm operating a slightly complex presentation system here as well, so if I get out of sync too, please forgive me, but I'll try and, if you don't like that title slide, you can use this one, ADHD throughout the lifespan. Like I said, my name's James Gardiner. I'm a forensic psychiatrist. I work at a place called Regional Youth Forensics Service at Auckland, and it sits under the Kari Centre CAMS, so the Child and Adolescent Mental Health Service for the community there. My work involves doing reports for the youth court and occasionally the adult court on a young youth, and it also involves going into the youth justice residences and treating young people in there for their mental health problems. And as you can imagine, a fair few of them have ADHD. And the statistics tell us it's about 40%, possibly even 50% as well. So it's somewhere around there. I'm also pleased to say that although we've increased our ability to recognise and treat ADHD over the last few years, we're still nowhere near where we should be, I suspect. And my practice has changed around this in the 3 years that I've worked for youth forensics, and that's part of what we're going to talk about today, as to how to engage people and get a treatment plan up and going. Before that, I worked at Mason Clinic, and my job was to go into Auckland Prison, which is New Zealand's only maximum security prison, and that's Auckland Prison East, and there's also Auckland Prison West, which has a couple of outer units with lower security prisoners. But that was also fascinating, and I did that for about 5 years and worked in Mason Clinic overall for about 8, including the latter part of my registrar training. So I'm very lucky to be here. I've been lucky to be asked. I talk a little bit about ADHD around the place, and I've put a few conference presentations together. So I like to think that I know a little bit about what I'm talking about, but this work that I'm presenting isn't mine, it's everyone else's. I'm just the person delivering it to you. And I look forward to upskilling everyone. So, quick introduction and we'll talk about the history and the epidemiology of ADHD, and then we'll talk about ADHD through the lifespan. So we'll start with children, which are all pretty simple, and we know what that looks like, and we'll move on through the lifespan. Talk a little bit about the sorts of comorbid presentations that go with ADHD. We'll talk about treatments, and we'll talk about what a coherent ADHD delivery plan might look like. And the spoiler is that it's not there yet. We don't have the skills at the moment. We don't have clinicians that are versed in and what the issues are and how to work with them. And so it's going to fall mostly on, I suspect, primary care to deliver in the meantime. And so we're going to talk a little bit about some tips for safe healthcare delivery, really. And then if I'm woefully short on slides, we can talk a little bit about ADHD in the high-risk populations, like prison populations, and we can talk about the prevalence and the effects of treating people in those environments. I suspect we won't be running short on time because I'll talk a lot and bore you all. Firstly, what we're talking about when we talk about ADHD isn't necessarily one distinct entity. It's not a phenotype. It's not trackable to one gene or two genes or anything like that. It's actually a whole complex morass of developmental and neurologically developmental issues. Tanya's talked a lot about adverse childhood experiences, and without a doubt they can impact on the frontal lobe and cause an ADHD-like syndrome. So what we're really talking about is hypofrontality. We're talking about people with poor frontal lobes, and there are multiple causes for that. So that's the first thing that's the first caveat I want to mention. Tanya was kind enough to flash up pictures of her kids, so I'll flash up pictures of my youngest daughter, who's certainly not got ADHD. She's won the trophy for the hardest worker in her soccer team. That was just taken a couple of days ago, and if you think the trophy's big, that's purely that was purely yeah. And then I've got another daughter, the older one, and I'm not sure whether she's got ADHD or whether it's just the food colouring that we feed her. But I think that putting pictures up of your kids is sort of a must-do when you're a proud parent. Right, so firstly, you come to places like this and you talk about ADHD and everyone sort of treats you like you've got the plague or something similarly infectious, and also not positive. It's a really controversial diagnosis, and these quotes are all things that have been said to me that encapsulate why it's been controversial, that the symptoms are vague and can't be easily measured. They're also non-specific, which is a problem, that people with ADHD often have personality problems as well, and that's very apparent and when they interact with others. Frontal lobe symptoms are non-specific, could be from anything, including depression or trauma or something like that. And of course there's a degree of normal human experience in what we all kind of I mean, we make jokes about ADHD all the time, kind of, in child and adolescent mental health because we're having trouble concentrating, but actually everyone has trouble concentrating anyhow. It's kind of totally normal. And that's even before we start talking about the treatment, which is, and when people think of ADHD, they think of stimulants, which is controversial to say the least, for various reasons. Where there's a good controversial topic, The Simpsons do a really nice job of piecing it all together, and this is from a Simpsons episode when Bart has ADHD and gets treatment on focusing, and then he becomes excessively focused and he ends up shooting down the Major League Baseball satellite because they're monitoring them from outer space, but the whole time it winds up that it's actually true. But my favourite medication here is the crystal meth. I think that's that's pretty good. And Milhouse, who's Bart's constantly anxious sidekick, is on Repressitol. So, but I urge you to watch that episode if you're at all interested. It's hilarious. But look, where I'm coming from, I've got a dual clicker thing going on here, so I don't want to get out of sync. ADHD basically can be viewed as a serious public health problems, and the outcomes for people with ADHD in terms of general health are very, very poor. Greater rates of emotional maladjustment, lower occupational attainment, more frequent job changes, increased risk of teen pregnancy, more pessimistic views of self, higher healthcare costs, poorer driving records, more pessimistic views of childhood, greater rate of STIs, fewer years of education completed, are some of the things that people have measured. And you also have problems with lower self-esteem, poorer social skills, sleep problems, and sleep problems are huge with ADHD. Greater rates of obesity, a lot of it impulsive eating, and problems with significant social maladjustment. What is ADHD? Well, it's probably the most common neurodevelopmental disorder seen in child and adolescent psychiatry, and it's pretty accepted that it's seen in about 3% of the population as the lower figure, and if you want to, you could go up to 5% of the population. Places that have got a role in promoting ADHD, like the ADHD Institute, which is actually a fairly well-recognised organisation, seems to think that it's 5 to 7% of children and adolescents and about 3.4% of adults. And I think it's also important to note that, like a lot of neurodevelopmental disorders, it's diagnosed a lot more in males than it is in females. In fact, there's pretty much no neurodevelopmental disorder where it's the opposite. If you want to look at, I accept that ADHD is very much a socio-cultural phenomenon as well, and these are the estimates from around the world. And as you can see, they're fairly wide in some areas such as Africa and South America, and in the well-studied areas in Europe and North America, both of which have 32 studies looking at the prevalence estimates of ADHD, the error bars become much narrower. But you're talking about 5 to 6% of the population prevalence is what people think. meet the criteria for ADHD. And I'll go back to the original caveat that I said, poor frontal lobe function for whatever reason. This is children and adolescents with ADHD, and there's 171,000 cases of ADHD in this slide. So this is a bringing together of all of the data. It's got a very interesting history. Starts in the late 1700s. Sir Alexander Crichton, who was a physician, first mentioned mental restlessness in a book that he wrote called An Inquiry into the Nature and Origin of Mental Derangement. In 1844, a man by the name of Heinrich Hoffmann wrote a book called Zappelflip, which stands for, sorry, I'm trying to muck around with my fidgety Phil. And here's some pictures. So he was a child and adolescent psychiatrist, and really he was a remarkable man, Heinrich Hoffmann. He was really the father of forensic psychiatry, in the sense that in those days, the pervading culture was that people might be possessed by evil, and he thought that criminal behaviour had a lot to do with mental health. So for a bunch of reasons, he formed a very well-known institute in Germany at the time where he lived, which took people in and did a lot of behavioural therapy with them, even though they were criminals. But anyhow, what he used to do when he used to engage kids is he used to draw. And so he'd draw them pictures, and that would be something which he would use as a tool to engage them. And then these drawings and these stories, these narratives that he had put together, became books. And this is a famous one called Fidgety Phil. And I'll read you Fidgety Phil, it won't take that long. Let me see if Philip can be a little gentleman. Let me see if he is able to sit still for once at table. Thus spoke in earnest tone the father to his son. And the mother looked very grave to see Philip so misbehave. But Philip he did not mind, his father who was so kind. He wriggled and giggled, and then I declare, swung back and forward and tilted his chair. Just like any rocking horse, Philip, I am getting cross. See the naughty restless child growing still more rude and wild, till his chair falls over quite. Philip screams with all his might. Catches at the cloth, but then this makes matters worse again. Down upon the ground they fall, glasses, bread, knives, forks and all. How Mama did fret and frown when she saw them tumbling down, and Papa made such a face, Philip is in sad disgrace. So this was thought to be one of the first examples of somebody documenting a hyperactive child. He also wrote another book called Johnny Look in the Air, who winds up wandering and having to get fished out of the canal, which I thought was also quite good. So that's Heinrich Hoffmann and his contribution to that. Sir George Still, in 1902, talked about a defect of moral control, and at this point in ADHD history, ADHD got a little bit confused with subnormal intelligence or other atypical neurological developments that it might occur as comorbid with. And so George Still was also a remarkable man, and he was the father of British paediatrics, essentially. He himself had 12 kids, which I imagine would have formed the basis for much of his training. And he spoke 4 ancient languages and was able to read and interpret manuscripts in all of them. So he spoke Greek and Latin and Hebrew and another one, which name escaped me. So he was a remarkable person. And essentially what he did is he described what we would call a hyperactive conduct disorder these days. Kids that were driven and on the move, but also did dumb things without realising the consequences, but would hurt others. And he presented this in a 1902 lecture, which was one of the real turning points, and actually one of the real beginnings of child and awareness around child development and child pathology. So he talked about passionlessness, spitefulness and cruelty, jealousy, lawlessness, dishonesty, wanton mischievousness and destructiveness, shamelessness and immodesty, sexual immorality and viciousness. The keynote of these qualities is self-gratification, the immediate gratification of self with regard to either the good of others or to the larger and more remote good of self. He also wrote, another boy aged 6 years with marked moral defect was unable to keep his attention even to a game for more than a very short time, and as might be expected, the failure of attention was very noticeable at school, with the result in some cases the child was backward in school attainments, although in manner and ordinary conversation he appeared as bright and intelligent as any child could be. Remember that at this time, very didactic view of good and evil was prevalent, promoted by various institutions, including religious organisations. So the whole idea around morals and people being potentially possessed or in league with the devil or whatever, not as strong as it was in the 1700s, but certainly was still there now. The other thing that's significant, I think, and very forward-looking is the fact that he was intelligent and yet struggled with school. So there was a disconnect between his ability and his actual attainment. And then Alfred Treadgold talked about high-grade, feeble-minded children, and he was a man who studied kids that had intellectual disabilities and unusual development. And he became a very important figure going forward because there was the encephalitis lethargica epidemic that occurred, that Kramer and Palno described in 1932. And what happened around the Great War is that there was an epidemic of a virus that caused a brain swelling, and afterwards people became irritable and struggled to concentrate and restless, and they attained a state that looked a little bit like ADHD, but in retrospect it was due to the damage to the frontal lobes as part of this. In 1937, the first medical grade amphetamines were discovered by Charles Bradley, and he was a Rhode Island paediatrician, and he prescribed this because he thought that people's brains were surrounded by a lack of CSF, or cerebrospinal fluid, and that caused the concentration difficulties and the restlessness. And he had quite a large and very popular therapeutic hospital in New York, in upstate New York, which admitted a lot of kids with behaviour problems, and he had remarkable success in treating these young people, most of them with Benzedrine, which was a fairly basic amphetamine-based stimulant at the time. The kids called these arithmetic pills, and he was very much of the belief that a lot of this problem manifests itself in maths difficulties. And so Charles Bradley wrote that some of these kids were characterised by a short attention span, dyscalculia, mood lability, hyperactivity, impulsiveness, and a poor memory, which is what we would suggest these days was a fairly good description of somebody with ADHD. In 1954, methylphenidate was introduced by Seba Geigy, and it was called Ritalin, and Leandro Panasian is the man who discovered it and invented it, and Rita was his wife, and that's the name that Ritalin comes from, so it's named after his wife. My wife has specifically asked me not to name any drugs or other substances after her as a result. In 1948, sorry, I'm just trying to work out where we are here. In 1948, people talked about asphyxiant illness in pregnancy, Rosenfeld and Bradley, so again brain damage manifesting itself as an ADHD-like syndrome. And then in 1957, the more modern approach around hyperkinesis and behavioural difficulties being part of normal neurological development in some people came along with Laufer, Tenhoff and Solomons publishing a specific paper on this. And this was adopted then into ICD by the World Health Organization, later into DSM-2 and DSM-3. And what they said is that the descriptions from around this time, and these are the Palo descriptions that we were talking about not long ago. Sorry, the Laufer descriptions that we were talking about. A number of indications for Ritalin, such as chronic fatigue, lethargy, depressive states, disturbed senile behaviour and psychosis associated with depression and narcolepsy. And so this is the uses of Ritalin around the time. And however, its most impressive effect has been a reduction of symptoms. So that's relating really to the introduction of methamphetamine and methylphenidate and Ritalin. Whereas Rosenfold and Bradley, who were discussing the asphyxiant illness, described a fairly uniform overt behaviour pattern of maladjusted children who have experienced asphyxiant illness in infancy. 6 cardinal behaviour characteristics make up this syndrome, may be listed as follows: unpredicted variability in mood, hypermotility, impulsiveness, short attention span, fluctuant ability to recall material previously learned, and a conspicuous difficulty with arithmetic in school. Once again, maths seem to be the struggles that most people had.
What do they mean by an asphyxiant illness in infancy?
So what we would call an APGAR, low APGAR scores, and
So birth asphyxia.
Birth asphyxia, that's right. Yep.
Did they make some sort of research connection between the two, or was this just a hunch that
So this was what they were doing, is they were following up asphyxiated children, and they were documenting the neurological state that many of them seem to manifest itself. So this is the whole link between brain damage and frontal hypofrontality sort of syndromes. This is how ADHD all came to develop, essentially. The shift then, they concentrated on this. This is related to the encephalitis lethargica epidemic as well. They had similar degrees of brain damage. And then if you think right back to the earlier stuff with the other guy, whose name escapes me just for a sec, but I'll zap back and grab. Alfred Treadgold, a lot of these studies were of neurologically abnormal people. And so what you had people describing ADHD, and then you had people describing ADHD in brain damaged people, and then you had people coming to the realisation that people that are normally intelligent potentially exhibit the same symptoms. My apologies, I'm having trouble dicing between the slides, it's really pain. And then Laufer, essentially, and this is very wordy and I apologise to this, but and I'll let you read through it rather than read it yourself. But once again, these people are describing a similar presentation in the brain damaged individual, and then they're going on to describe that essentially in kids with softer signs of neurodevelopmental abnormality or neurodevelopmental abnormal sort of development. And so what they're saying is that both people with brain damage and people without brain damage can exhibit these symptoms. So the more recent history is the methylphenidate started being studied in emotionally disturbed children with good results. DSM-2 started talking about a hyperkinetic reaction of childhood, which was the first real official time that ADHD was put in a diagnostic manual. 1969, Connors started doing his work, and he came up with a rating scale. It was initially a fairly basic rating scale, but then he expanded that into a rating scale for parents and teachers as well. 1981, Russell Barclay wrote a seminal textbook really on hyperactive children and a handbook for diagnosis and treatment. And then in the end, in 1987, ADHD went into DSM-3 in the revised version, very similar to the current DSM definition of ADHD. There's also a bit of controversy happens around that time, and you have to understand a little bit about what was happening in America at that time. That was when the crack epidemic was on, and particularly in New York City. And if you look at the abortion literature, you find that around the 60s, early 70s, there were a lot of unwed mothers having children in the midst of this crack epidemic. Abortion got legalised, and then the crime rates dropped in the early 90s rather dramatically, and it was 20 years essentially after the abortion was legalised that those crime rates dropped. But Rudy Giuliani, amongst other people, claimed credit for stamping out the crap epidemic by broken windows policies and longer sentences and things like that. But essentially around that time, and this is very similar to what we've got in New Zealand at the moment, is that people are terrified of people on stimulants, really. Crack cocaine's fairly potent. We've got methamphetamine that's more potent and does more damage to people than what any other drug that we've known through history. So in no way condoning methamphetamine, of course, but around the time, people were very scared of stimulants, and particularly the people that weren't going to use stimulants, the middle class people with young children. And so a 1970 Washington Post story came out, and it talked about in Omaha, Nebraska, 5 to 10% of children receiving Ritalin for their to assist them with their schoolwork in the school system there. What it didn't mention is that these were kids in special education classes. It wasn't kids in the mainstream classes at all. In 1970, the people started realising that having a lot of Ritalin around can be diverted for criminal use as well, and so they made it a Schedule 3, and then the following year a Schedule 2 medication, which shifts it up in the realm of penalties that you can get as part of a criminal if you're busted for it, and also makes it much more difficult to prescribe and much more strict monitoring. In 1979, there was definitely an anti-Ritalin movement, with a number of books being published that questioned both the diagnosis of ADHD and the use of Ritalin in ADHD. And this prompted a response from the American Psychiatric Association, which basically said, look, some kids really benefit from this, and we think it's a very important thing to continue along the lines of. So the current diagnostic schedule represents the development of ADHD over a century, and now we've got longitudinal studies as well, where we've followed a cohort of young people with ADHD, and we see it as a chronic illness. It's also highly heritable, and there's theories around about it being related to Vikings, who apparently had ADHD when they were pillaging back through Europe back in the day. Furman, ADHD is not a disease per se, but rather a group of symptoms representing a final common pathway for a gamut of emotional, psychological and or learning problems. And so that's him saying that ADHD is where brains that are traumatised or diseased wind up, and that he's a anti-ADHD writer. So, and look, there's certainly some validity to that, without a doubt. And the other concerning thing about the diagnosis is that the cardinal symptoms of inattention, impulsivity and hyperactivity are not symptoms that are unique to ADHD, and they can be related to any illness that affects the frontal lobes. The rating scales between parents and teachers, when you do them, are frequently discrepant, and I see this all the time in my day-to-day practice. But over the last 5 to 10 years is that the fMRI, which is the functional MRI stuff that people do, when they put them in an MRI machine and then do a task a cognitive task, watch the brain light up as the blood flow increases to particular areas, they're generally supportive of a phenotype of ADHD in general. And these are slides that I've stolen from people at overseas lectures. This one. They talk about the ventral medial prefrontal cortex and the dorsomedial prefrontal cortex. The AIC is the anterior something or other cingulate, and then there's the striatum and the amygdala. And this is how these parts of the brain all relate to each other when they're given a task around concentration or around attention. And so what they do is they look at the parts of the brain that they're interested in, and bits that are lighting up and bits that aren't lighting up, and they're trying to work out in what order they've got. And I was just at the European Conference for Child and Adolescent Forensic Psychiatry, and they're doing trials now where they reckon they've got like a way in which somebody with a callous and unemotional response to other people's emotions lights up amongst these sorts of areas, and they've found that treating conduct disordered kids who don't have ADHD with Ritalin can really assist the lighting up order in which it's all done, which is going to be very, very interesting going forward. Let's talk a little bit about ADHD in children. Does anyone have any questions in particular about that, the general history, epidemiology, things like that?
Can I just ask that last comment that you made?
Yes, the throwaway one that I shouldn't have said.
Does that mean that, like, if they're emotional, that you can actually get the Ritalin to work on the emotion then?
That's correct. Yes. So and
And make it worse.
No, make it better.
Make it better.
Okay, make it better.
Yeah.
Okay.
Yeah. Which is interesting. We'll talk a little bit about how Ritalin works later on, which is very useful as well, and it might explain some things. Okay, so here's DSM, and I apologise for quoting DSM, but it's kind of the manual that we use, whether we like it or not. But the cardinal feature of ADHD is that people with ADHD show a persistent pattern of inattention and or hyperactivity/impulsivity that interferes with functioning or development. Nothing particularly controversial there. I won't read this slide to you, that would probably be a little insulting. But essentially, these are symptoms of inattention. 6 or more symptoms of inattention for children up to the age of 16, 5 or more for adolescents 17 and older. Symptoms of inattention have been present for at least 6 months, and they are inappropriate for the developmental level. The idea that 6 or more symptoms of inattention for 16 and 17-year-olds is actually quite new, and one of the people, and we'll talk a little bit about why that happens, why they've changed it to reflect that in this edition of DSM a little bit later.
It's not just a typical adolescent.
That is just a typical adolescent, isn't it? Yes. And that's what people say. But I guess what they say is inappropriate at a developmental level. So that's one really important phase. And you've just ruined my slide 3 or 4 slides from now by saying the other thing is that they're present for 6 months as well. So you've got to measure it against all adolescents. And then hyperactivity and impulsivity. And so once again, 6 or more or 5 or more for adolescents, 17 and older and adults, and they've been present for 6 months to the extent it is disruptive and inappropriate for the person's developmental level as well. The other conditions of the DSM diagnosis, several inattentive or hyperactive impulsive symptoms were present before the age of 12 years. That used to be 7 years, but what happened is the people that worked in adult ADHD found that the cognitive ability to compare yourself to your peers often comes along at the age of 8 or 9, and it was really, really hopeless asking them what they were like when they were in early new entrant stages of school, because kids don't really compare themselves in retrospect to other kids. They don't have that awareness and that level of individuation from others around them yet. The symptoms have to be present in 2 or more settings, so your normal adolescents at school, they just might be like that at home, but not like that at school or in their work or with their friends or something like that. There's clear evidence that the symptoms interfere with or reduce the quality of social, school or work functioning. And of course they don't happen when you're in the midst of a psychotic episode or something similar as well, which requires more urgent treatment. It shouldn't need to be written, that last point, but psychiatrists often aren't that great at working that out for themselves, I'm ashamed to say. So, this is the slide that you ruined. Inappropriate for developmental level. And so I thought I'd just highlight that, and I thought I'd also highlight that with hyperactivity and impulsivity as well. But that's really important. And so the self-report questionnaire and the main psychometric that we would use would be the Conners. And the great thing about the Conners is that you open it up, that's the first thing, and it's got 100 questions on the inside of the page, all in tiny little font. And somebody with ADHD kind of recoils and goes, oh my God, how am I going to do that? Or they just grab it and start circling. and somebody without ADHD says, I'm going to work through that in a slow and organised manner. But that's the great thing about the Conners. But the other thing is the Conners has ADHD symptoms in there, and it also has symptoms around mood problems and oppositional defiant problems and conduct problems. And what it does is it maps them against the developmental level. So one answer for a 10-year-old would be different to another answer pattern for a 16 or 17-year-old. Keith Conners is a very smart man, and probably quite wealthy right about now as well. So.